Hello, my name is Jones Muna. Today, we look at nephrotic syndrome. Introduction. Nephrotic syndrome is one of the major glomerulopathies. Nephrotic syndrome is not a single disease, but a group of disorders or symptoms including albuminuria, edema, hyperlipidemia, and hypoalbuminemia. This syndrome causes damage to the glomeruli with resultant proteinuria. Nephrotic syndrome is more common in children, although it can occur in adulthood. Definition. Nephrotic syndrome is a clinical state that includes massive proteinuria of greater than 3 grams per day, hypoalbuminemia, hyperlipemia, excessive total fat in the blood, and edema with significant damage to the glomeruli, resulting in severe loss of proteins. Wang et al. 2000. Classification. 1. Primary nephrotic syndrome, minimal change nephrotic syndrome, childhood nephrosis, or idiopathic nephrosis. Approximately 80% of the cases of nephrotic syndrome in children result from minimal change nephrotic syndrome. It can occur at any age, but the disease is more common between 2 to 7 years. The disease is rare in children under 6 months and under 1 year. It is also uncommon after the age of 8 years. The cause of minimal change nephrotic syndrome is not known. 2. Secondary nephrotic syndrome occurs as a clinical manifestation after or in association with glomerular damage of known or presumed etiology. 3. Congenital nephrotic syndrome. This is the hereditary form of nephrotic syndrome which is caused by a recessive gene on an autosome. Infants who have this type of nephrotic syndrome are usually small for gestational age, and proteinuria and edema are manifested early. The disease does not respond to the usual therapy. Dialysis or successful kidney transplantation will be helpful, otherwise the baby is likely to die in the first year or two of life. Risk factors. These are classified into 2. 1. Primary glomerular disease. Acute glomerulonephritis, 75% of the cases of nephrotic syndrome occur as a result of acute glomerulonephritis. 2. External causes. Multisystem disease. Metabolic diseases such as diabetes mellitus. Sickle cell disease. Amyloidosis. Infections. Syphilis. Herpes zoster. HIV. Hepatitis. Infective endocarditis. Rheumatoid arthritis. Toxins from parasitic infections, such as severe malaria. Neoplasms. Malignant tumors of the kidney. Hodgkin's disease. Leukemia. Solid tumors of the colon, lungs, stomach and breast. Circulatory problems. Congestive cardiac failure. Allergic reactions. Drugs such as sulfonamides, heroin or captopril. Other. Trauma to the kidneys. All these conditions will result in increased glomerular permeability to plasma proteins, allowing them to seep out of the body in urine. Pathophysiology. The pathogenesis of nephrotic syndrome is not well understood. There may be a metabolic, biochemical, physiochemical or immune-mediated disturbance that causes the basement membrane of the glomeruli to become increasingly permeable to proteins. The glomerular membrane, normally impermeable to albumin and other proteins, becomes permeable to proteins, especially albumin, which leak through the membrane and are lost in urine, hyperalbuminuria. This reduces the serum albumin level, hypoalbuminemia, reducing the colloidal osmotic pressure in the capillaries. As a result, the vascular hydrostatic pressure exceeds the pull of the colloidal osmotic pressure, causing fluid to accumulate in the interstitial spaces, edema, and body cavities, particularly in the abdominal cavity. Ascites. The shift of fluid from the plasma to the interstitial spaces reduces the vascular fluid volume, hypovolemia, which in turn stimulates the renin-angiotensin system and the secretion of antidiuretic hormone and aldosterone. Tubular reabsorption of sodium and water is increased in an attempt to increase intravascular volume. The elevation of serum lipids is due to urinary loss of lipoprotein components which decrease the activity of lipolytic enzymes, and this results in impaired clearance of cholesterol. Clinical manifestations. Periorbital edema in the morning in the early stages of the disease, which later becomes generalized, anersaka, due to seepage of fluids in the tissues. Proteinuria due to increased permeability of the glomeruli and capillary beds to plasma proteins. Reduced urine output as a result of hypovolemia. Diarrhea due to edema of the intestinal mucosa leading to malabsorption. Irritability and fatigue due to discomfort. Hematuria due to increased permeability of the glomeruli and capillary beds, which allows some blood cells to seep out in urine. Breathlessness due to pulmonary edema. Blood pressure is usually normal or slightly decreased, but sometimes the children have persistent hypertension because the blood vessels are compressed by edema, and this causes resistance to the flow of blood. Raised blood pressure is also due to the stimulation of the renin-angiotensin system. Anorexia due to edema of the intestinal mucosa. Weight loss from poor appetite. Changes in the nails, that are white lines, that are parallel to the lunular due to prolonged hypoalbuminemia. Susceptibility to infection, especially cellulitis, pneumonia, peritonitis or sepsis. Abdominal swelling from ascites. Abdominal pains due to accumulation of fluids in the peritoneum which causes irritation. Extreme skin pallor due to seepage of blood cells in urine. Management. Diagnosis. History from the patient. Parents will usually give history of the child being well but steadily gaining weight and then becoming anorexic, irritable and less active. Clinical presentation of the patient such as generalized edema and anorexia. Urinalysis that will review high levels of albumin in urine. Blood studies that will review hypoalbuminemia and hyperlipemia. Kidney biopsy which will review malignancy. Intravenous urography that may review malignancy. Treatment. Effective treatment of nephrotic syndrome requires correction of the underlying cause. However, treatment is supportive. Steroids, prednisolone 1 to 3 mg kg BWT orally. It is known to decrease proteinuria, increase urine output, and therefore edema reduces. Diuretics, potassium-sparing diuretics. The drug of choice is spironolactone to increase urine output and thus reducing edema. Antibiotic therapy. X-pen 25,000 IU 6 hourly if infection arises, and also to counteract relapses of nephrotic syndrome that are often associated with recurrent infections of the urinary tract and respiratory tract. Antihypertensive drugs if the patient presents with hypertension, for example, nifedipine or methyldopa. Iron supplements. Ferrous sulfate and folic acid in case of anemia. Cytotoxic therapy, cyclophosphamide or chlorambucil to reduce the rate of relapses. Complications. High susceptibility to infections because of loss of gamma globulin in the urine, an immunoglobulin protein that contains most of the antibody activity. Coagulation disorders due to massive loss of proteins through urine. Ascites due to an increase in pressure within the portal vein which forces fluids in the abdominal cavity. Congestive cardiac failure because of reduced blood volume in the circulation. Malnutrition because of anorexia and also because of loss of proteins. This is the commonest complication. Renal failure because of reduced blood volume in the circulation and also because of kidney damage. Cerebral hypoxia because of reduced cardiac output. Hypovolemic shock because of seepage of fluids into the tissues. Thromboembolic disorders because of raised blood pressure that causes rupture of the blood vessels leading to thrombus formation. Hypertension because of the stimulation of the renin-angiotensin system and also because the blood vessels are compressed by edema causing resistance to the flow of blood. Nursing care. Objectives. To reduce the excretion of urinary protein and maintain protein-free urine. To prevent or treatment of acute infection. To control edema. To establish good nutrition. To readjust any disturbed metabolic processes. Environment. The patient should be reverse barrier nursed as he is susceptible to infections. The room should be clean and free from dirty to prevent further infections. The room should be free from dangerous objects as the patient's vision may be impaired because of periorbital edema. Bed rest. The patient should be on complete bed rest to promote quick recovery. To promote rest, procedures should be done collectively so that there is minimal disturbance to the patient. The room should be quiet and free from noise. A prescribed sedative should be given to promote rest. For example, diazepam 5 to 10 mg NOCT. As the condition improves, the patient can do moderate activities such as brushing the teeth. Position. The patient should be nursed in semi-Fowler's position to aid breathing and to reduce periorbital edema. As the condition improves, the patient can assume any comfortable position. Observations. Vital signs will be taken 4 hourly, that is, temperature to detect infection, pulse rate and blood pressure to detect any cardiovascular system complications, such as hypertension. Respirations should be done to detect any difficulties in breathing. Urinalysis will also be done which will review high protein levels and oliguria. Thanks for listening and keep studying.